revolutionary, particularly in the area of lymphoma.
And so somebody who's just a radiologist, I sometimes call them picture readers because they look at these scans and not to demean it, because it's critically important that you pick up on things, that the image is good and that the scan is read correctly, because that's critical in terms of catching a diagnosis early, potentially missing a diagnosis. So it's a very important aspect. But you're not just a radiologist, you're a radiologist oncologist. And so you use radiation to actually treat people with cancer, right?
That's correct. So all radiation oncologists definitely do have training in diagnostic elements, because we use these tools every day in designing our radiation treatments. But actually a radiation oncologist uses high energy radiation actually to treat cancer. And that's the difference between a diagnostic radiologist and a radiation oncologist.
And so most of them, we were joking before, usually they're located in the basement of the hospitals. In your case, you're not, you're on the ground floor. But when people think of radiation for treating cancer, they think usually of external beam radiation. And so in my case, they fit me for a mold, and I sit in the same spot every time, and they would line up to get the radiation exactly where they wanted it to go.
Right.
But how does it work? How is it that radiation actually kills the cancer cells?
Well, radiation works by damaging the DNA of the cancer cells. And we, both with chemotherapy and radiation therapy, we exploit the difference between the cancer cell's inability to repair damage to its DNA, the building block of the cell, and the normal cells that can, if they're injured by radiation, can repair damage. But the basic way radiation works is it creates something called a free radical that then goes on to damage and cause breaks in the building block of the cancer cells, and the cancer cells cannot repair that damage and they die. So that's basically how radiation works.
And so you can apply it through that external beam. And Charlene had mentioned some of the refinements with the 3D techniques and so forth, so that you could actually maximize the amount of radiation going where you want it to go and minimize the radiation to the undesired areas, the unaffected parts.
That's right. Using what we just spoke of earlier, CT scans, we can refine the target, try and identify a more localized area that needs radiation, and then using computer-controlled designing of radiation, which is, I think, what you described, what you saw in the basement at the other institution. Using computer-controlled radiation, we can essentially conform or carve the radiation beams so they now can spare the normal tissues. Like in the case of treating the chest, we can spare the heart, we can spare normal lung that doesn't need radiation, and maximize the dose to the target, but spare normal tissues that we want to protect from radiation.
And so just briefly, some of the forms of cancer that radiation is used for, and then in particular blood cancers.
Okay. Well, radiation therapy plays a key role in the management of breast cancer, which is my area of specialty, lung cancer, prostate cancer and other genitourinary cancers, gynecologic malignancy like cervix cancer and endometrial cancer plays a very important role in brain tumors. It helps us preserve extremities and other organs in patients who may have soft tissue tumors called sarcomas. So those are just a few of the areas where radiation plays a very important role. It also plays an important adjunct role after surgery in cancers of the GI tract, so pancreas cancers, rectal cancers, things like that. In terms of blood cancers, that's a very interesting area. Particularly in the area of lymphoma, radiation therapy was actually one of the primary and early curative treatments for blood cancers, particularly Hodgkin's disease. That has now, we now play an important role, but as with the development of better chemotherapeutic drugs and some of our knowledge about some of the long-term effects of radiation, we now attempt to use lower doses of chemotherapy and much lower doses of radiation therapy together to cure blood cancers or lymphomas.
And in fact, there were a lot of studies for some of the aggressive lymphomas back when I was going through this, showing that you could use less rounds of chemotherapy, and using chemotherapy in combination with radiation actually produced a better result than chemotherapy alone.
Right, and there was just actually a very important study that came out in a major journal this week that looked at use of lower doses of chemotherapy or fewer cycles of chemotherapy and lower doses of radiation, about half the dose that I would have given when I was in training, that produced very effective cure rates in patients with Hodgkin's disease.
And typically when we think of external beam radiation, we think of the radiation going to a particular area of the body. But I know for some patients with Hodgkin's lymphoma, they've been given something known as full body radiation.
That's correct. I mean, radiation also plays a role in the treatment for more advanced disease, advanced blood cancers in part of what's called the preparative regimen as part of high-dose chemotherapy and bone marrow transplant or stem cell rescue. And in that case, we may be asked to deliver radiation to virtually the entire body to both wipe out the rest of the lymphoma and then prepare the individual to receive the reinfused stem cells.
And Dr. Griem, you guys, meaning radiologists, oncologists, aren't just satisfied with the external beam. I know that there's a lot of other ways you get radiation to the cancer tumors and cancer cells, radiation seeds. In the case of lymphomas, radioimmunotherapy, which includes something like Rituxan, which is a monoclonal antibody we've talked about before, in combination with radioactive isotopes. So you get there, you attach onto the cancer cells with the monoclonal antibody, and then you nuke them with the radiation.
Right.
Could you explain that?
Sure, absolutely. In addition to external beam radiation, which is pretty much what we've been talking about, there are other ways of using radiation. One is with what's called implant radiation therapy, or brachytherapy is the term we use, where we actually may insert radioactive seeds into the part of the tumor that the tumor-bearing part of the body. Like a good example is we use radioactive seeds frequently nowadays in treating prostate cancer, and that's a very, very successful form of treatment and spares the patient the need to come for 6 to 8 weeks of outpatient radiation therapy. The other way is to use what are called unsealed sources in the use of treatment of lymphoma with targeted agents, which are where a radioactive isotope is attached to a monoclonal antibody, and those target the lymphoma cells and deliver the radiation therapy precisely to that area, sparing other normal tissues from radiation.
Which, I mean, it's tremendous development. Mm-hmm. And this is all within the last, 6, 7, 8 years?
Absolutely, with the use of monoclonal antibodies, yeah. Right, absolutely.
And the results, have been cures for people and patients with some lymphomas that just a few years ago were thought to be incurable, maybe could be in remission for an extended period. So, I mean, these are developments that are making a big difference in a lot of patients' lives.
Right, absolutely.
So, somebody comes to you, and they're like me, they're a chicken and they're a coward, and they're afraid that you're going to nuke them with this radiation stuff. But if somebody's going to see a radiologist for treatment, what are some of the tips you can give a patient?
Well, I mean, I think we do, as radiation oncologists, understand that this is an unfamiliar area to many people. They may be familiar with surgery, they may be familiar with chemotherapy, but this is generally a new area to most of our patients. And so we're very accustomed to the educational role the radiation oncologist needs to play. So I think it's very reasonable to ask the radiation oncologist what the purpose of the radiation therapy is, like with your wife, what area is going to be targeted with the treatment. How did the physician arrive at the dose that's going to be used? How is it going to be administered? What are the anticipated early side effects, which are temporary, and what could be possible long-term effects, and how are those prevented? So those are all very reasonable questions to ask the radiation oncologist, and he or she should be very comfortable answering those.
And briefly, because this could be its own show, but what are some of the common side effects, and then the things that, because for every side effect, you generally have something to help the patient through it? Absolutely.
Most of the side effects of radiation, what's really important to know is they're temporary. They're called what's called acute or short-term effects, and they're temporary. And it's important to realize radiation is a localized treatment, so it's only going to one part of the body, and the side effects of the treatment are generally related to the part of the body that's being irradiated. So, for example, if we irradiate the scalp, there may be temporary hair loss, or if we irradiate the extremity, there may be a temporary sunburn reaction that'll go away. If we irradiate the chest, sometimes there's a little bit of irritation of the esophagus and some sore throat, but all of these side effects will go away after the treatment's over, and your physician has remedies for all of these to help the patient get through treatment.
Well, I think even though we focus the Chicago Blood Cancer Foundation and Battling and Beating Cancer on blood cancer, we cannot let you go. You're an expert at breast cancer, and breast cancer is so pervasive. So I want to ask you a few questions about that. First of all, mammograms. When should women get them, and how often?
Well, that's certainly a controversial area right now, but I think it's generally in our program, we usually follow the American Cancer Society recommendations, which are the mammography start for women without a family history start at the age of 40, and that women strongly consider annual mammography as a very effective screening tool. Obviously, a woman can discuss this with her physician as to the interval, but I think the message we want to get out, this is a very effective, cost-effective tool for detecting breast cancer early, and the general recommendation is that a woman start considering mammography when she turns 40.
And I would also say this, because I'm not bound by the AMA or anything else. I think that's ridiculous to push back the guidelines that far, because there are a lot of young ladies in their 20s and even younger with breast cancer, whether it's birth control induced or otherwise. And so, all the guidelines are great, but there's no substitute for talking things over with your individual doctor.
Right.
And particularly if you see something, self-breast examination, very important. If you see something, you got to go to the doctor and you got to talk with your doctor. That's probably the best advice we could give.
Right, absolutely. I think this is something for each woman to discuss with her physician, but to strongly consider regular screening mammography.
And once again, in the area of breast cancer, the final question I'm going to ask you on that is, there have been some developments in treatment of breast cancer through radiation.
Absolutely. I mean, radiation is a very, very effective tool for treating breast cancer. Now we're studying better ways to target the breast, and we're also studying more improved regimens, which may shorten the course of treatment, so a woman may not need to necessarily come for 6.5 weeks of treatment, which is the conventional regimen, but rather shorten the course of treatment to around 3 to 4 weeks. And that's been shown to be very effective and obviously very satisfying to the patient.
And so, Dr. Griem, once again, another doctor we're presenting to you on Battling and Beating Cancer that's the type of doctor that you want to go to, somebody who's the top in her profession, but yet somebody who's compassionate, who cares, who will take the time to explain things to you, and is invested in helping patients and helping find cures, right?
Sure.
And that's what brought you into medicine in the first place, isn't it?
Yes, absolutely.
Thank you so much for joining us.
Thanks for having me.
And we're going to bring Charlene back in just for a moment or two, because we have to let her have the last word. We know that you're going to be out there. We're only about 30 days away from our Out for Blood bike ride, and that's the way that you can come along and help us, help you, and help everybody out there by finding better treatments and cures for cancer. And look at that, just by the magic of the button.
All
here
right.
is Charlene.
Okay, that was really, really good. And next Wednesday at 7:30 on Battling and Beating Cancer on CAN TV 21, we will be joined by registered nurse Sharon Manson and physician's assistant Katie Ellis. And the topic is helping you through side effects of chemotherapy and radiation. And once again, we want to thank Dr. Griem, our producers Dorothy and Christy, who are here with us every week, and to you for watching. And we will see you next Wednesday at Battling and Beating Cancer on CAN TV 21. And
thank you all for joining us once again. And not only will we bring you great doctors, but all the doctors will tell you it's important to have the whole medical team that is there to serve you. That includes nurses. All of us who have been through radiation and chemotherapy know the importance of good nurses, physician assistants, the people who draw your blood, the people who check you in. It's a team effort. And you also need somebody by your side who's going to advocate for you, especially when you're going through treatments and you're not up to par, you're scared, you're not feeling good. You need somebody like a Charlene, a family member, a friend, somebody who will look out for you, ask the questions, make sure that you're getting the best treatment. And so until next week on Battling and Beating Cancer, good night, everybody.
thank you. Good night.